Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Millicent Rovelo, and I'm here today with my most favorite co-host, Dr. J. Calvert. How are you?
I'm good, and I'm excited about this topic today because it's an interesting one.
Yes, this is an interesting topic about breast reduction, but specifically breast reduction in the context of an implant placement at the same time. So it's like a subtraction addition thing to breast reduction.
Hold on a second.
Yes, hold on.
You're saying that you're going to do a breast reduction
Make the breast smaller.
and then put in an implant.
Yes, that's correct.
Okay.
Yeah, you're correct.
That sounds
Curious.
like something we need to unpack that a little bit for our
Yes.
people.
And I want to say right off the bat, this is similar but different from a mastopexy augmentation. So a mastopexy is a breast lift with an augmentation, with an implant. So you are lifting and putting volume into the breast. Commonly, this is done for women who have lost a lot of weight or who've had babies and breastfed and just have a lot of loose skin of the breast that need to be lifted, but they also want to add a little bit of oomph and volume. So those are mastopexy augmentations. What we are talking about today are women that come in for almost a therapeutic breast reduction. Their breasts are heavy, they have a lot of weight to them, they want them to be significantly smaller. But at the same time, they want to keep or maintain or create upper pole fullness. So this is the fullness that's at the superior aspect of the breast.
Yeah, and that's the key is that we're really not trying to make the breast bigger. Obviously, we're doing a reduction.
Right.
So we're taking away breast tissue anywhere from 200 grams up to 2,000 grams or 3,000 grams, as some of your breast reductions will get there. But then the implant is used as a reconstructive device to help shape the new version of the breast.
Right, because a lot of times what happens, and this is very dependent on a patient's age and the quality of their breast and their breast tissue, is that with a breast reduction, the question we always get asked is, do I get a lift with this? Yes, but I don't really call it a lift. I call it more a repositioning of the breast mound. So I take the volume that's low, sometimes sitting almost next to the belly button, and I lift it and resuspend it back onto the breast at the time that I do the reduction. But it still keeps a very natural breast shape to it, which usually means there's a little bit of emptiness up top and it's fuller on the bottom. Now, in some women, particularly young women or women who have very dense breasts, they can get a lot of upper pole fullness because they have a lot of solid breast tissue up there. And so they don't need anything extra added. The reduction alone can give them a nice full breast. But the average breast reduction patient, especially if they're older, they're not going to have that fullness up top because they just don't have breast tissue at the top part of their breast.
Right, and that's the thing is typically all the quote-unquote breast over the pecs is like skin.
It's skin. There's very little actual tissue.
Yeah, and then the breast kind of starts around the inframammary fold and everything's low. Yeah. And, they want, you want pretty breasts. You want them to be perky and lifted and in the right position. So that's hard to do with just the breast tissue.
The breast, which is why we use implants. And they can be very small implants. They don't have to be large by any means. But even a small implant can give a significant amount of fullness to just the top part of the breast, and the rest of the breast makes up the natural part of it. When I first started looking at doing these, I always struggled with exactly how to do this because by definition of technique, any surgical technique you use for a breast reduction, you really are taking apart the entire breast. Mm-hmm. You're lifting skin and breast flaps, you're rearranging tissue, you're taking out large parts of it, and you're really left with this big open space. And then when you try and put a breast implant in, you can put it under the muscle, the pectoralis muscle. It's really hard to keep that implant in place because all of the soft tissue barriers that would normally keep an implant in place under the muscle have been completely taken apart and taken down. Yep. And so it wasn't uncommon for that implant to sort of slide off to the side and end up close to the armpit because there was no natural barriers keeping it where it was supposed to be. But then Galaflex mesh. If you haven't figured it out by now, I love Galaflex mesh. I use it for everything.
But you have no financial interest.
But I have zero financial interests Just
you
putting it out
should.
there.
They should be.
I have 0.
Yeah, so nothing to disclose. But I'd be happy to get
I'd
something.
be happy to disclose.
Yeah.
So Galaflex mesh, and this is the name brand of the actual mesh, but there are other versions of this out there.
There are.
The component of it is P4HB. It's a synthetic mesh that actually is created from microbiomes, so there is sort of a biologic component to it. But it's not a permanent mesh. It goes in to support soft tissues, but over the course of about 6 months, your body puts its own fibers and collagen fibers onto the mesh, and the mesh itself dissolves. And what's left behind is a strong soft tissue component. But where it works really well for implants is creating the pocket that I need. So I can use it, I can put it laterally on the edge of the pectoralis muscle and sort of recreate where the border of the breast used to be before I took it all down when I did my breast reduction. And that works really well at keeping the breast implant in place where I want it.
Yeah, I mean, that's a key component. There are other devices you could use too. You could use stuff for like an acellular dermal matrix. You could use... I like to use the lateral breast flap if I can, the deepithelialized, where we've taken the external skin off and used the dermis of the actual breast skin to use that as the kind of pocket control mechanism. Published that in ASJ a few years back. But the whole concept, and I remember, by the way, that when I was doing a lot of these massive weight loss surgeries in my residency at the University of Pittsburgh, they were kind of like, don't use implants in people that, you need to reduce the breast, or they have too much skin, or they were too heavy at one point. Now they've lost all the weight because you can't control the pocket.
Right.
Well, now you can.
Well, now we can.
And that's the key, because to get a pretty breast, in fact, I had a patient I saw on Thursday that came in. I had done a abdominoplasty and a mastopexy for her, a tummy tuck and a breast lift, and she went on Ozempic. And now she's like,
that's not helpful for your surgery.
I need some help with these breasts. They're like gone, and they deflated because she lost a lot of weight. So we're going to put some implants back in her after the mastopexy. And she was sort of a reduction mastopexy too. So it's the same concept. You want to be able to use the implant to make a pretty breast.
Right. But in this case, we actually are removing the breast, or actually removing breast tissue. So it's not really adding a whole lot of extra weight. So just by the numbers, say an average breast, there's no average breast reduction, but I'm trying to think of the last one I did. We took out about 450 grams on one breast, which is equal to about a pound. And then we put in an implant that was like 160, 190 cc's.
Aww.
It was so cute. It looked like a little silver dollar pancake.
It's a little pancake.
And the woman herself had fairly broad shoulders, so she could have used a wider implant. But it doesn't matter. We're not using it to make volume.
Right.
That little tiny small implant was more than enough to give her just that little bit of oomph and volume that she needed, but not at the cost of adding extra weight to the breast.
Yeah, it's all about shape. It's all about making the breast project, filling in the upper pole. It's a really important concept.
Right. And for these patients, this is the one time I will use a drain in a breast reduction. Typically, I don't need a drain in my breast reductions. For this one, I do, just because now that I have an implant there in a foreign body, I really want to make sure no fluid accumulates, no blood accumulates. I treat it a little bit more differently because the complication profile changes and goes up a little bit because we have all these foreign bodies, the mesh, the implant. So I do put a drain in these patients, but otherwise the recovery process is more or less the same. A little more discomfort than an average breast reduction because I am lifting the pectoralis muscle, so you do experience that. But again, the implants we're putting in are so small that it's not that big of a stress.
Yeah, they don't need to be big.
Yeah.
You just need it for it does make a difference for control of the breast tissue, and the difference to me is night and day. It's like, okay, I'm going to have like a low breast with no upper pole fullness versus putting in 100. I usually put in like maybe 200 cc implant, but I guess you could do 160.
This patient wanted to be a B cup.
That's fine. Yeah, it's all good.
So she went from being like a triple D, and she's like, I want to be a B cup, but with volume. So this was perfect. We took out a lot of volume and then put in a tiny implant, and she has the cutest little B cups.
And it works. And that's the key. And so knowing when to do that is really key. That's why you go to somebody with lots of experience, such as yourself, myself. I do a lot of these because and this was also another topic that back in the day, when I was getting done my training, like people would say, like, don't do implants with a mastopexy, like not necessarily even a reduction, but like they say, do the mastopexy first or do the implants first, or they wouldn't want to do them simultaneously. And I just don't know how you build harmony for the breast by not doing them simultaneously. So at the time of the reduction, if you know that you're talking about shape, maybe that's the time to make the decision to put it in an implant.
Right. And it's not for everyone. Not all breasts are going to be amenable to it. But if you have the right kind of breasts and your tissue's loose enough, then putting a small implant in at the time of the breast reduction can be lead to a really nice result. If you're trying to go through this with insurance, maybe insurance covers the breast reduction. They will not cover the implant. They will not cover the mesh. Just know that up front. And then if you're going out of pocket for all of it, then it doesn't really matter. So it is an extra cost. It is an extra expense, but it can give you a really nice breast shape.
Let me ask you a question. Do most of your reductions that you do in an implant, are you placing the implant under the pectoralis muscle, submuscular, or are you placing it just behind the gland or subfascial?
I'm doing it under the muscle.
You do?
Yeah. Because
does that make it harder?
Well, not if I use the mesh, because now I've walled it off completely and it has its own little pocket and its own little home.
Got it.
If I put it above the muscle, I don't really have a great place to fixate the mesh.
Right, it's unruly.
Yeah, so it really has a lot more place to slip and slide around in.
Yeah, I mean, typically with these amazing Motiva implants and even with the Sientras, I really prefer subfascial placement when I'm trying to use the implant to generate the look of the breast.
Right.
But for this, under the muscle makes a little more sense because all you're doing is trying to get volume.
Trying to get a little volume. And when you're doing more of an implant or a mastopexy augmentation, you're removing skin, but you're not really deconstructing the whole breast.
Right.
So you're not taking apart the whole space. So it makes sense you can put the implant wherever you want it.
Can I ask you another question?
You can.
What pedicle do you prefer to use? And what I mean by that is, what is the blood supply that you leave for the nipple areolar complex? You can refer to our podcast on nipples from a little while ago. But what blood supply do you like? Superior, medial? Do you ever use inferior, medial? What's your pedicle choice in terms of getting the best look for the breast?
I typically do a superior or a superior medial pedicle. So the blood supply comes from the top or the top sides of the breast.
Me too. I like that one.
Yeah, that's a good one. Although I do more central pedicles if I'm doing a pure breast reduction or breast lift in combination with Galaflex mesh. Doing a central pedicle makes it really easy to put the mesh where I want it in the lower portion of the breast. So it depends.
Yeah, I mean, I don't do inferior pedicles. I typically do superior medial pedicle. I mean, that's the volume you want to keep anyway. However little there is, why take it away? I never understood the concept of the inferior pedicle breast reduction, but that seemed. I don't know if it's still the most popular.
I don't know. Some people still do it.
And it was like when I was training, people like doing a superior medial was like, whoa, that's crazy. Like you're doing that, and now it's like. I wouldn't do it any other way. Yeah,
I think that's probably getting to be the standard. But again, it's whatever your surgeon feels comfortable with. Yep, and if they're getting great results that stand the test of time, that's all that matters.
That is very true. It's every surgeon will tell you whatever it is that they're doing is the best way to do it. And what they should say, it's the best way for me to do it. Because it is the best for them to do it that way. It doesn't mean it's the best or whatever, but in their hands, they're saying, I do inferior pedicle techniques because it's the best for me to do this for you.
Right. And if you like the results, it doesn't matter what they do.
Doesn't matter how you do it.
It doesn't matter.
Nope.
So, yeah.
So like the deep plane facelift, smash facelift, like if they make people look great.
Who cares?
Who cares how they get it done?
Absolutely.
You want it to be awesome. That's all, period.
End of story. Well, anything else you want to add to this addition, subtraction podcast?
No, I think it was really good. I think people will... they'll put two and two together that it does make a difference in terms of the reduction to get a beautiful breast using a device maybe indicated in their case. Yeah,
all case-by-case basis. And in that case, this is the Beverly Hills Plastic Surgery Podcast coming to you from the 90210.